Good evening, everyone, and welcome to the first of our 2025 webinar series from the Swiss Neurogastro-Motility Network. People are still dropping in, but I will start with the introduction. This is a webinar series that we started quite successfully last year, where we cover all sorts of aspects within the realm of neurogastroenterology and motility, covering both clinical and scientific aspects. And the goal is to give an update on how to manage these patients and how to best care for these patients who we see quite frequently in our practice. It's a great pleasure to have this webinar series today, supported by Schwabe Pharma. Thank you very much for their support. And we have two excellent speakers with a broad knowledge both and exposure both clinically and scientifically. The topic we will be covering today is a very frequent disorder of gut-brain interaction, functional dyspepsia, that we are all more or less familiar with and hopefully will be more familiar with at the end of this presentation. To start us off, it will be Professor Daniel Pohl from the University Hospital of Zurich, who will guide us through the definition, pathophysiological aspects, and diagnostic workup of these patients. And that will be followed up by Dr. Ioannis Linas, who is from the GI group practice in Bern, who will then show us what management options we have in those patients. So without further ado, Daniel, I will give you the screen and hand it over to you.
Thank you, Lukas, for the introduction and for helping to manage this webinar series. So good evening, all of you. A pleasure to be here tonight with you guys. And yeah, let's talk about functional dyspepsia. I'll start with the more general part, I would say, and then I look forward to hearing what Ioannis has to say about the treatment of functional dyspepsia, and then hopefully a lively discussion. So to get started, we are now dealing with the realm of functional GI disorders. And if we are dealing with that, then number one, we don't like the name, and I'll talk about that maybe in a minute. But secondly, functional dyspepsia is considered part of the gastroduodenal disorders. So it appears to be not just a stomach problem, but also the small bowel is somehow involved. And you can also see that looking at this list of so-called functional GI disorders as per Rome 4 definition, is that this is only a small spectrum. However, a significant spectrum that we see a lot in our practices, even if we're, or especially for an ambulatory care, and gastroenterologists probably see 1/3 of the patients dealing with this realm of diseases. So this is something I like to point out also when I talk about IBS, that we really don't like the term functional GI disorders because it is controversial, it's unclear. It simply means that we don't know what it is, or that we don't understand it. Certainly doesn't mean that there is nothing. That would be the most wrong of statements. So now they're classified as disorders of brain-gut interaction. And if you look at a little bit of the history with the example here of IBS and constipation and bloating and distension, they used to be separate disorders. Then they were considered overlapping diseases, and then they became something of a continuum which moves from symptom to symptom. Let's say if you're more constipated, if you have less pain, it's functional constipated. The more pain you have, you're walking towards the realm of then IBS-C. And the same is true for functional dyspepsia, possibly together with gastroparesis. There's now more and more people that believe that this is also one spectrum of disease. If you measure gastric emptying times in functional dyspeptics, you often find a pathologic gastric emptying time. The symptoms overlap anyhow. If you measure again a year later, about half now have normal gastric emptying. So this is also something which probably is a continuum which moves spectrum-wise between gastroparesis and functional dyspepsia. If you have a patient that comes with dyspeptic symptoms, which is not functional dyspepsia. It's unexplained dyspepsia. So be sure to make that correct in your reports. When a patient comes with dyspeptic symptoms and you haven't done the proper workup, and I'll tell you what I think that is, then this is unexplained dyspepsia. And this is very, very prevalent, probably 20% of the world population have that. It's more common in women, more common in people who smoke and who take medication. And one of the biggest medication dyspeptic symptom inducers are non-steroidal anti-inflammatory drugs. Generally, this is a disorder which causes high costs, both direct, because you're in the health system, you get all these workups done, and secondly, also because you miss out on work, you miss out on work productivity. It's a chronic, recurrent, and persistent problem with a negative impact on your quality of life. A lot of these patients self-treat with over-the-counter preparations because the symptoms are usually of short duration and mild severity, and that's the mainstay of dyspeptic patients. We don't even see those, or we don't see many of those actually. And then there's, which I've mentioned briefly, the influence of the quality of work. 32% were absent from work in the last week. This was from one study using the Rome 3 criteria, and almost 80% consider themselves less productive as if they wouldn't have these symptoms. So what about the global prevalence? This has been dropping over the past 30 years due to changes in the definitions of Rome, most likely. The current worldwide, after the Rome 4 study, the Ramis-Berber study, the prevalence is probably around 8%. So it's still prevalent, but it's come down to what it was considered before, roughly 12%. Women are more frequently affected than men, with an odds ratio of roughly 2.7. The prevalence is higher in developing countries, so this is not a third world problem, it's a global problem. And again, the prevalence is higher in developing countries. Why? Because the prevalence of HP is higher. Now, we'll sort HP out in a minute. Is that dyspepsia, functional dyspepsia or not? But also because there are more risk factors to develop functional dyspepsia, and one of those main, or the main risk factors to develop functional dyspepsia is after gastrointestinal infections. So what about the definition? This is the current the definition we've been using for now actually quite some time. The Rome 4 criteria are now close to being published again for Rome 5, but currently it's still Rome 4. And dyspepsia or functional dyspepsia means a disturbing postprandial feeling of fullness, an early feeling of satiety, disturbing epigastric pain, or an epigastric burning sensation in the last 3 months. Symptom onset has to be more than 6 months ago. And importantly, no evidence of a structural disease, including an upper endoscopy, that could explain the symptoms. So this also means that if you haven't done an upper endoscopy, you cannot make the diagnosis of functional dyspepsia. There's 2 subtypes. These subtypes have been sharpened a little bit with the last Rome edition, and this has also been shown in studies that is the case. There's less overlap now, because there used to be a lot of overlap. It's less overlap now. And the main 2 entities are the PDS, the postprandial distress syndrome. This is, I would say, the classic functional dyspeptic patient who has disturbing postprandial feeling of fullness, early feeling of satiety, which means that he can't finish a normal meal. He has this at least 3 times a week. And there are supportive symptoms such as postprandial burning of pain, flatulence, belching, and nausea. Then there is the more difficult and more rare epigastric pain syndrome. This is not necessarily meal-related. This is disturbing epigastric pain. It's primarily pain and or burning sensation, but not retrosternal, epigastric. At least once a week. Supportive, the pain can occur during eating or fasting. Doesn't have to be. Can be relieved by eating. Doesn't have to be. Additional bloating, belching, or nausea. And if you look on the pie chart on the right, you can see that currently we have about 18% overlap between the 2 entities, about 70% the PDS, and about 10% EPS. Now, whenever we do our structured analysis and our structural history taken in gastroenterology, we look for so-called red flags. And these red flags are a little bit debatable, but these are, I would say, some of the more established ones for functional dyspepsia. This is the symptom onset now if you are older than 40. So this has been coming down a little bit in recent years. Significant weight loss, more than 3 kilograms. Dysphagia, unexplained dysphagia, you always need to scope, no question. Chronic vomiting of icterus, and then nocturnal symptoms. Nocturnal symptoms can occur in functional dyspepsia, but you still have to check these patients more thoroughly. Findings that you may have in your status, like elevated temperature, status abnormalities, or positive fecal immunotesting for blood traces. Then in your lab, if you have anemia, if you have signs of inflammations, such as leukocytosis or an elevated CRP, or abnormal chemistry, which indicate possibly a liver or kidney problem. There are a number of differential diagnoses, but there's also a number of overlapping entities. Probably the two most overlapping entities are gastroesophageal reflux disease, which we've covered in a different talk, in a different webinar, and IBS. And looking at the data which are out there and our own data, there's between 30 and 50% of patients who have IBS also have functional dyspepsia. So ask also for upper gut symptoms if you see your IBS patients. SIBO may or may not play a role. Food intolerance play a role. Celiac disease. We currently know 1 or 2 out of 7 patients who have celiac disease in Switzerland. This was Swiss-specific data published a number of years ago. So always check that. Drug-induced, especially NSAIDs, which I've pointed out before, are important. There's maybe biliary causes, liver pathology, intestinal oxygenation issues such as angina intestinalis, chronic inflammatory bowel diseases, pancreatitis, malignancy, infiltrative gastric diseases such as eosinophilic gastritis or sarcoidosis, and then metabolic disorders such as hypercalcemia or heavy metal poisoning. So what do we find, or what can we find if we do more additional testings, or if we do actually research exams which are not available in clinical practice? There's a number of things you may find. I already mentioned delayed gastric emptying. Another significant thing that you may find in these patients is problems in their fundic accommodation. So these are the patients that tell you they have a knot in the upper belly, which when they eat doesn't relax. That's exactly what's happening. The stomach doesn't relax. The fundus doesn't relax upon meal ingestion. Physiologically, it would ingest. You can eat more. These patients, this may not be the case. There's a number of data. Some are clear, some are unclear about low-grade inflammation in the duodenum and what kind of low-grade inflammation that is. But this has been, I would say, of stronger interest in science in recent years. And then there may be visceral hypersensitivity to mechanical stimuli. So you may just, once your stomach is full, you simply are more symptomatic. So there's a number of things which are involved, gastrointestinal sensory and motor dysfunctions, and I alluded to that. Then the central nervous system plays a role, the hypothalamic pituitary axis, stress and CRH. This may also interact with the duodenal eosinophilia and endothelial dysfunction, central processing of GI stimuli, hypersensitivity, hypervigilance, correlation with psychosocial comorbidities. And then there's coming, I would say, data on the microbiome. Some studies have shown more Streptococcus, less Provotella, Veillonella, and Actinomyces, and some other studies showed bacterial load in the upper small bowel in the duodenum correlates with symptoms intensity. I think this is still in a quite open book. This is a nice graph from Nick Talley's group, which looked at health and FD and looked at duodenal possible barrier defect, duodenal content and dysbiosis, and then the local immune activation, changes in the local neurons, and then systemic immune activation. So I would say the more we look into the pathophysiology of functional dyspepsia, also in IBS, by the way, the more we look at lymphocytes, mast cells, mast cell mediators. There's a renewed interest in histamine now, and local immuno and also allergic processes, IgE-mediated processes which may play a role in sensitization of afferent nerve fibers and then in the end symptoms. So we are far away from being simply a psychogenic disease. I alluded to risk factors previously, and one of the major ones is having had a gastrointestinal infection. There was a meta-analysis, an older one, roughly 20 studies, 10,000 people. Prevalence of functional dyspepsia after an enteritis was almost 10%, odds ratio of 2.5. And some of the more suspected pathogens which are involved in the evolution of functional dyspepsia are Salmonella species, E. coli, Clostridium jejuni. Then especially Giardia, probably the most severe case I've ever seen of functional dyspepsia is a patient who had a resistant Giardia infection, and then also norovirus. Yeah, and there was also another controlled study that looked at Giardias and to a fourth of people who have had a Giardia infection develop functional dyspepsia. How about diagnostics? This is, I would say, still rather short. You do test for your alarm signals, you do blood work, you do inflammation markers, you test your liver, your pancreas, you look at your kidney. Importantly, always look at celiac disease. So do your transglutaminase antibodies and a total IgA. You cannot have the diagnosis of functional dyspepsia without an upper endoscopy. And if you do that, you need to take biopsies in the stomach to look for HP. And you also need to take biopsies in the small bowel to exclude celiac disease, to look at any problems with the local mucosa, and also exclude Giardia or other small bowel chronic infections. In all the countries where the ultrasound is in the hands of gastroenterologists, abdominal sonography is part of the routine workup. The therapeutic gain is small as far as the data are concerned, 1 to 3%. Mostly those are incidental findings. We only very rarely find a reason for the symptoms other than functional dyspepsia, but it's simple, it's harmless, and it's inexpensive. I can talk to the patient at the same time. So it's a standard, at least in Switzerland it is. I discussed or started discussing HP before. HP used to be a risk factor, probably still is, for the development of functional dyspepsia. However, let's say you find HP and you eradicate that. Then after the Kyoto Global Consensus, and then also in the following Rome criteria, it was established that if your symptoms improve and if you have a sustained relief after successful eradication of HP for 6 to 12 months, then this was HP. It was HP-associated dyspepsia. And if that is not the case, if your symptoms recur earlier than that, or if you don't respond to the treatment, although you've successfully eradicated, then this is not HP dyspepsia, but probably functional dyspepsia if you've done all the testing. Another test that we like to do is we like to challenge the patient. And to make it simple, we use the same test that we also use for our IBS patients. And as I said earlier, half of our patients overlap anyhow. And why is this nice? Because it's a volume, it's a meal, it's 400 ml of Ensure. So this is 600 kcal. It has fat, it has proteins, it has carbs in it, and also fermentable sugar. So we like to see if our patients get symptoms right after that. And if they do, then this is indicative of upper GI symptoms. And this is something that we like to do, although it's not an established test. There are some established tests also from the Living Group, like the drinking test, where you ingest water up to a certain amount. Depending on how much you can drink, you're more likely to have functional dyspepsia or not. So this is a simple test that could be done, but I personally like our approach in looking at that. And why do I also like it? Because I want to look at the FODMAPs, because there's also some data now that if you do a FODMAP diet, then this actually helps in alleviating symptoms of FD. And if you have an underlying IBS, the more so. FODMAPs, just to remind you, are fermentable oligodisaccharides, monosaccharides, and polyols. And if you look at how they cause symptoms, they may cause symptoms only in the lower gut. And I've shown this slide in my IBS talk. Depending on what you eat, what's the enzymatic composition in your small bowel, what's your fructose glucose ratio, what's the condition of the intestinal mucosa, what's your transit time. This may move to the lower GI tract, either the distal small bowel or then ultimately the colon, and then lead to the influx of water and gas formation. And again, because this is these osmotics effects already happen in the small bowel, this is where it may be causing symptoms. And there's also some immune effects that I'm not mentioning here, which are also play a role in the generation of symptoms. So this was how FD is currently defined, and how we classify it, and also what kind of workup makes sense in most of these patients. And now I look forward to hearing from Ioannis how we manage FD once we establish the diagnosis. Please, Ioannis.
Thank you very much, Daniel. I will quickly jump in while Ioannis is preparing. So I'm sure you have a lot of questions, remarks, or ground for discussions. We will do a Q&A and discussion round at the very end of this. So feel free to write your questions or remarks in the chat, or then at the very end to do the hand raise emoji, and we will get the discussion going after the presentation of Ioannis. Please, Ioannis.
So I hope everybody can hear me and you can see my slides also. Can you please confirm that?
Yes, lovely. Perfect. Everything works.
So I'll talk about the management of functional dyspepsia, and my small talk is structured like this. So I'll begin with communication with the patient, then some thoughts about lifestyle, diet, psychotherapy, and then I'll focus on the medical management. And I will show you some recent data, not to dive deeply in the studies, but more like food for thought. My problem in the management of functional dyspepsia is that there is great discrepancy between guidelines in Europe and in the US and across the world. I think there's probably no other condition that there is such a discrepancy, except for infectious diseases with, country-specific bacterial resistance. Various guidelines tend to focus on some parts of this disease. So what you are going to see in my talk is mostly my summary of the guideline data and a little bit of my own experience. So feel free to challenge me or to take it with a grain of salt, as you wish. So I think the first part of, the first part of the treatment in all DGBI patients, so with diseases of gut-brain interaction, is the explanation of the diagnosis, or the communication with the patient. And we are always surprised at how many patients do not require anything else except for that. So if we take the time and explain to the patient what exactly he has and why he has it, then some of them will go on with their lives and their quality of life will actually improve through that simple intervention. So what I always say to the patient is that I reassure them that there is no risk of complication with functional diseases. I acknowledge that their symptoms are real and not imaginary, and that not everything is in their mind, that they're not psychiatric patients or mentally ill. And there are sadly still many patients that come with such ideas or such comments from other colleagues or GPs, and they are a little bit oriented that way. Then, of course, we have also to manage expectations. And I tell the patients from day one that for these diseases, there is no one-fits-all treatment. It will be a trial and error. Of course, we can profile patients based on symptoms and prioritize treatments over other treatments, but still there's a long way to go, and the patient has to be ready to take that approach. If not, then we won't have a good result. So if the patient is impatient, he will end up stopping treatments, switching treatments too early without having any proper effect. So if the patient still questions my thoughts and asks, okay, how can I be ill if you found nothing in the gastroscopy? How can I be ill if the labs are okay? Then I take some time to explain them how hypervigilance in the brain-gut axis works. I think all of us maybe have had such discussions with the patient. So I take a look if they wear trousers or a watch, and then I ask them, can you feel your trousers? And then they take a couple of seconds and they reply, yes, I can. And then I ask, did you feel your trousers a minute ago? And then they say, no, I didn't. And that's how the discussion begins about how stimuli from the periphery, from our gut, are being triaged in the brain. And there are many stimuli that should be actually scotomized. They shouldn't be felt. But if you're in a state of hypervigilance because your brain is focused on your stomach or on your guts, then you end up feeling much more than you should. And normal processes like the passage of food or digestion, they end up being felt and augmented, maybe even as pain. So where do we begin with these patients? We always discuss a little bit lifestyle, and we recommend training, both aerobic and anaerobic. We recommend avoidance of NSAIDs, coffee, alcohol, smoking, so everything that could actually work toxically on your stomach. But the truth is we don't have much data on that. So there are empiric recommendations. We hope that they help. They are sometimes also difficult to implement, but we don't have studies to support that in functional dyspepsia. There's also much talk about dietary modifications. Daniel also mentioned some aspects here. The truth is also that the efficacy for functional dyspepsia at the moment is globally unclear. Even all studies fail to identify specific food triggers for functional dyspepsia. There are studies that show that if we involve a dietitian, we may actually get some benefit for our patients through an individualized approach. And maybe the PDS type patients that have rather bloating than pain, they may be the best candidates for that. And there are results on the low FODMAP diet, like Daniel mentioned, but they're a little bit contradictory. So the one prospective randomized trial for functional dyspepsia did not show a difference from standard dietary advice, but there are retrospective studies that show that it might be of benefit. So we have similar problems in the field of psychotherapy. So contrary to IBS, where we have solid data about psychotherapy, in dyspepsia, the image is not that clear. There are meta-analyses and reviews that show that globally there is an effect of psychotherapy, and probably there are 3 interventions that are the most beneficial. So relaxation therapy, hypnosis, and cognitive behavioral therapy. I think I'm not the only one in Switzerland having the practical problem of finding a psychotherapist or psychiatrist that is interested in investing time in gastrointestinal patients or has appointments before 2 months, before 1 year, I'm sorry. So there are some practical disadvantages in the implementation of psychotherapy in our everyday life. I hope you have a better experience than I have, but I would like to use it much more than I do for DGBI patients, but I'm not in a position for the moment. And then, of course, we have a medical therapy, which is still the mainstay of treatment for functional dyspepsia. And as Daniel mentioned, there are many mechanisms that contribute to the symptoms of functional dyspepsia, and thus every treatment has specific targets. So most of the treatments we use, they work on multiple targets, but if we try to group them based on the main target they focus on, then we have treatments that work mostly on gastroduodenal motility, like the prokinetics and procalcipride, erythromycin, and Iberogast. We have treatment working mostly on mucosal function, like the PPIs, the H2 receptor antagonists, which are also a little bit difficult to find in Switzerland, the tricyclics and caraway oil. And we have treatments affecting the gut contents, like the low FODMAP diet, and treatments focusing on the gut-brain interaction itself and on the sensitivity of the stomach and the duodenum. And there are many of them listed here. So I have to say, for the medical treatment, I'm focusing on patients with functional dyspepsia. That means I won't discuss eradication of HP or other treatments that have been already excluded if we have a patient that actually has functional dyspepsia in the end. And I would recommend to read a recent review of Douglas Drossman in Gastroenterology about the modulators of the brain-gut axis. It was published in 2024. It was focused rather on IBS patients, but still it's mostly discussion of medications and their way of action. I learned a lot from that review, and it helps us understand why we would use a specific category of neuromodulators compared to another category in specific patients. So if we take the main 4 categories that we use in our everyday life, so we have the SSRIs, which are probably the most commonly used, which are focused on serotonin. And because of that, they actually work better on anxiety and depression, and not as much on pain or bloating. So they maybe are the worst category for functional dyspepsia or for IBS, but still the most commonly used. If we add norepinephrine, so if we add the SNRIs, then we have a nice effect on pain. So these are medications that have a much better analgesic effect than the SSRIs. And if we take the tricyclics, which also work on muscarinic and cholinergic receptors, they have an even more potent effect on pain, but at the cost of some side effects like dry mouth, dry throat, orthostatic symptoms, some cardiac symptoms, and problems. But of course, we have to say that these side effects are much more common on the high doses used in psychiatry, like, for example, 200 milligrams amitriptyline per day for depression rather than 10 or 20, 25 for functional dyspepsia. So at our doses, it's really seldom that the patients have significant side effects. And then we have the tetracyclics like mirtazapine or venlafaxine that also have an effect on bloating. So that helps us triage or better select the first line neuromodulators that we'll use on a patient. Of course, we can augment them or combine them with others in case of insufficient effect. So then if we take specifically the two main subtypes of functional dyspepsia and how we would proceed with a patient presenting with this subtype, so that will be, again, the steps I would take and I would propose. With white background, I mentioned the steps that I'm expecting the GP to take. That means that if I see a patient for a gastroscopy or in the emergency department or somewhere in the ward, then I would recommend those steps to be taken for a specific duration and consequently. And if they don't work under these conditions, then I'm ready to see the patient to discuss the next ones. So for EPS, for patients presenting mainly with pain, we would start with PPIs, which should be given at the standard dose for a duration of 4 to 8 weeks. There were studies also comparing the double dose PPIs and didn't show advantage for functional dyspepsia. So we should give the standard dose. In reality, I also try the double dose. Sometimes I begin with a double dose just to be sure that I don't miss the small percentage of patients that would probably respond to a higher dose. And we don't actually know why PPIs work on functional dyspepsia. Is it a reduction of acid because some patients are really sensitive to acid and are overreacting, also are oversensitive to acid? Or is it the reductions of eosinophils in the stomach and in the duodenum, or mast cell modulation, or the accommodation of permeability? But the truth is they work on a great subset of patients. So if the PPIs don't work on an EPS patient, the next step would be to try some kind of phytotherapy like ibrogast or carmentine, again, for a duration of 4 to 6 weeks. So we have to try long enough before we say that it didn't work, because there are many patients that will respond after 4 weeks or even after 6 weeks to these medications. And then if we fail to improve the situation, the next step would be neuromodulators. In that case, we have to deal with pain mostly. So tricyclics like amitriptyline, beginning at low dose, 10 milligrams a day for 2 to 4 weeks, and then reassessing and augmenting to 20 or 25, or an SNRI like duloxetine would be the first step. If we reassess the patient in a month or in 6 weeks and we don't see any improvement, then we can increase the dose. With amitriptyline, I would go up to 50 for functional dyspepsia. With duloxetine, we can go to 120. And then the question is, what do we do if the patient is still not responding? And then I think it's a little bit of time to take a step back and to assess if we're missing something. So is it definitely functional dyspepsia what we have here, or should we run a little bit more of a workup? So just an abdominal CT or a CT angiography, or maybe gastric emptying, maybe consult a rheumatologist, maybe think of cell-tone diseases like porphyria presenting with pain, or maybe testing for food allergies or intolerances for patients with food-related meals. And then, of course, that would lead to more advanced therapies like H1 blockers or mast cell stabilizers to combination neuromodulation, or if we find some delayed gastric emptying, we would discuss GPOM or even surgery. And there are also patients that will respond to acupuncture, or patients that will have to be referred to a pain clinic in the end. Then if we take a patient with PDS, so mainly presenting with postprandial symptoms, early satiety, bloating, and so on, then Daniel already mentioned that we have to think about an overlapping constipation. If there is overlapping constipation, I think we have to prioritize the treatment of constipation and reassess the patient once the constipation has been treated. And then the first-line treatment in that case would be probably prokinetics like metoclopramide or domperidone at the standard dose of 3 times or to 4 times a day for a duration of 4 weeks. We could also use low-dose erythromycin, which is a potent prokinetic, and with the low dose, it doesn't stop duodenal motility or slow down duodenal motility, which is a problem that we have with the higher doses, which could be worsening symptoms. The problem is liquid erythromycin has been taken off the market in Switzerland. We hope it will come back, but I guess we'll see. Second-line treatment would also be phytotherapy here. So Iberogast has some kind of unique effect on gastric motility. It tends to help with fundic relaxation, to accelerate antral motility at the same time. So help the patients take up more, a greater quantity of the meal and empty the stomach faster despite that. And Carmentine also reduces pain and bloating on studies. Again, the duration should be at least 4 weeks, if not 6 or more. Then the guidelines also recommend the use of PPIs. I think there will be a subset of patients that could benefit from PPIs in PDS, although they're not as much as in EPS. And then we end up with more advanced therapies like the neuromodulators. And I think in that case, we have to think about tetracyclics like mirtazapine, which has a nice effect on bloating, on feeling bloated in prospective studies. And again, tricyclics would also be a very good option like amitriptyline. And once more, so if we fail after so many lines of therapy, then we have to think again about the diagnosis. Are we sure that we have missed nothing? Do we want a little bit more of a workup, like, again, gastric emptying, measure pyloric distensibility with an endoflip, maybe measure colonic transit if we're not sure about constipation, test for food intolerances or for SIBO with postprandial bloating and fullness, and maybe again abdominal or vascular imaging, and that would again lead to more advanced therapies in that subset of patients. So that would be my approach to the treatment of these 2 subsets, and I would like to show you some papers that have been published in the last 2 years, so very, very, very fast. It's not like they're the top methodologically done studies, but I think they're interesting things to keep for the future. So there was a review published in 2023 on capsaicin that showed that it may alleviate symptoms of functional dyspepsia. That was based on human and animal studies. And there were many hypotheses as to why it would do that. And we see that capsaicin has actually the potential of altering some parts of the gut-brain interaction, also the sensitivity and the microbiome. So maybe it would be something to study a little bit better in human trials in the future. There was a prospective randomized controlled trial of auricular vagal nerve stimulation, published 2024, three groups, 2 frequencies of vagal nerve stimulation and 1 sham intervention with a stimulator switched off. They showed a good response on both groups of stimulation, although there was also a high placebo effect, so a sham effect, which is not seldom with DGBI, so we're not surprised to see that. So that maybe would be something that will also come for this patient in the future. And the interesting thing was that although the duration was 4 weeks, the effect remained after 12 weeks of follow-up. Then there was an animal trial of electroacupuncture, which tried to understand why it would work for chronic pain and specifically for functional dyspepsia in animal models. And it showed that it could actually normalize pro-inflammatory cytokines. Of course, we know that when those animal trials, when we try to extrapolate them to humans, then sometimes we don't see the same effect, but it would be also something interesting for future research. Then there was another study trying to understand, based on functional MRI of the brain, which patients would respond to acupuncture for functional dyspepsia. And they actually managed to do that with a pretty good sensitivity and specificity. So maybe we can also use a study in the future, so an MRI, to select patients for this intervention. Then there was a review for probiotics in functional dyspepsia that showed again that we don't have specific data to recommend probiotics at this time. There are many limitations of the trials done up to now, and most of them show simply controversial results. There was again another meta-analysis of prokinetics, and it showed that there's still good effect on functional dyspepsia. If you see that there is also some kind of comparison, although it's not a head-to-head trial, so it's a forest plot meta-analysis, so I wouldn't dare to say that metoclopramide is better than domperidone. Probably it is, but we don't have enough data to say it at the moment. Then there was a trial of curcumin with combination with omeprazole, curcumin alone and omeprazole alone for 1 month for functional dyspepsia. There was, of course, no placebo arm, and it showed that omeprazole alone was more effective than the combination or than curcumin. Curcumin alone showed also a significant effect on functional dyspepsia, but of course, there's no placebo arm, so there's no way to tell if it's something that we are going to be using in the future or not. Then there was a study that also I showed in the SGG, which I was part of also, with mentacarin, that would be carmentine, where we included patients with functional dyspepsia and IBS, so it wasn't only functional dyspepsia, but we studied for a duration of 2 months under treatment all the main symptoms separately, including bloating, abdominal distension, and abdominal pain, and we showed that there was a significant decrease in all of the symptoms separately during this time. Sadly, I'm not allowed to show you any graphs or any specific results because the study hasn't been published yet full. We submitted only the abstract at the moment, but we hope to get it published soon. I also forgot to include the last one, a study from Brennan Spiegel and Brian Lacey from the US on the use of VR, virtual reality, for functional dyspepsia. They randomized patients on virtual reality and sham virtual reality, and they also had a good effect from virtual reality, especially on nausea and bloating. Interestingly, even the sham intervention had a certain effect on heartburn, regurgitation, and nausea, but not on the other symptoms that the VR arm had. So that would be all from my side. So if you have questions for me or Daniel, we'll be glad to take them.
Thank you so much, Ioannis and Daniel, for these nice presentations. Again, questions are more than welcome through the chat or by raising your hand emoji. I will maybe kick it off with a question to the both of you. You both, or especially Daniel, mentioned the H. pylori story, and is it now post pylori dyspepsia or functional dyspepsia? In practice, how do you manage this? We know that these patients, if they get better after eradication, it will take a couple of months, in which they will maintain symptoms. So do you start just after eradication therapy? Do you start a symptomatic therapy as well, or how do you specifically manage that situation?
Yeah, so we always test for HP. Number one, we always treat HP. Unless the patient has been treated 3 times, we've tested the strain for resistances. Usually we find out that it should have worked, what we've given the patient, because the resistant of that individual HP was met. So that's sometimes the point then when we stop, by the way. So for a functional dyspeptic, I also have a way of stopping that treatment. But the response to therapy varies between, I would say, people that respond rather quickly within 2-3 weeks after the treatment. And in some of them, it takes a long time. The definition when this is then called functional dyspepsia, that's the one where you have to wait for 6 to 12 months. So the response may be earlier, but again, if symptoms relapse, it's not functional dyspepsia. So I see the patients usually after 3 months again. So I give them some time. And then nothing precludes me from adding symptomatic treatment. So I'm not going to wait for 6 to 12 months for the patient to become symptom-free, but I do it symptom-based as possibly as Ioannis was suggesting in his talk, how to go about PDS and EPS. But no, absolutely, you can definitely start symptomatic treatment before that, and then you obviously at some point you may not need it anymore. But I do this as the patient wishes, if you like.
Great, thank you for clarifying. Yes, please.
Hi there, Lukas. Hi, Daniel. Thanks for the talk. That was great. I just want to do a kind of reality check. Everything that's been said is correct and is in the protocols, but the number needed to treat for PPIs and for Helicobacter pylori associated dyspepsia is probably about 10. And that may well be worth a try. But of course, there is this small problem that Daniel kind of alluded to, that it can be quite difficult to get the people off the PPI because of this idea of acid rebound, and one should at least be prepared for that. And then Douglas Drossman is an absolute hero, but those medications, I mean, I don't know if you guys have tried giving buspirone and this kind of thing. My patients just fall asleep. I mean, they just impossibly sedating. And I do wonder whether the Americans see the same people that we do, because I do use low-dose amitriptyline and trimipramine, and those have seemed to me very helpful, and they're also quite well supported by the literature, especially in people who have no severe gastric emptying delay. But the other stuff, I may be alone here, but it seems to me to be very difficult to use because of predominantly the sedative side effects.
So I can take that if it's okay. I mean, I am actually using neuromodulators very often. I think like you, like Daniel also, especially for patients with IBS, so a little bit less for functional dyspepsia, but still also for functional dyspepsia. And I mean, you mentioned buspirone. We don't have it for,
no, I mean,
that was in
years.
I mean, I don't know if they have it in the US, why they include it in this review, but still, I think it's not produced anymore. But anyway, for the other ones, I have to say, I have had surprisingly low side effects for amitriptyline 10 milligrams. And if you do wait a month before increasing,
it's the long list of other things, Ioannis.
Yeah. Yes. I mean, if you combine it, of course, with quetiapine, then you will have a sedative effect. And I think that's also maybe part of the treatment. So if you have patients that suffer from sleep disturbances, patients that have taken other medications to induce or to maintain sleep in the past, which are a part of these patients, then they will profit from quetiapine. Mirtazapine also has a mild sedative effect, but at the dose of 15 to 30 milligrams, we also seldom see it. I don't know, with what medications and at what dose have you had the need to stop them?
Is a good example. My patients can't take mirtazapine. Lots of them fall asleep. And a really bad.
At which dose do you give it?
And it's, but don't get me wrong. If it works, I mean, I get the concept, and I'm fully on board. But it's simply we don't have the perfect medication, and that brings me to an important thing. I'm just sending everyone obviously, we do need better treatments, don't we? No one's going to disagree. And many of you will have been sent the SwissNGM flyer about the kickoff meeting for the network study in gastric dysfunction in Bern. And I mean, anyone that's really interested in all of this, it would be great if you could be there, and we can then talk about auricular nerve stimulation and G-poem and all of the other kind of things that we may be using far too rarely at the moment.
So, Mark, jumping in on your remarks about Remeron. Remeron is an interesting substance, or mirtazapine, because the dose effect in terms of sleep induction is a little bit reverse. So you should actually start with a higher dose rather than with a lower dose.
Really? Okay.
It's less sleep inducing if you use a little bit of a higher dose than a lower dose. So don't start with 7.5.
So what's your dose to begin
So I
with?
start with 15. And also the effect after 2 weeks tends to get a little bit less. So tell patients to start out slow but don't give them 7.5. It's going to be more sedative than 15. This is not true for the other ones, but for mirtazapine, that is actually true. Then, I mean, for HP, we don't really have an option, because if once we've tested it, we need to treat it. It's a WHO carcinogen type 1. There's no discussion. We do that, right?
Yeah.
The PPI, I'm on board. I'm not a huge fan. I actually almost never use the PPI. I tend to use in both arms the phytotherapy first, because I feel like I don't harm, and I feel like it works in a lot of patients, especially the uncomplicated ones, if you like. For EPS, obviously, it's a little bit more difficult. Those patients, in my opinion, almost always end up with amitriptyline low dose, if they because the pain rarely gets treated well by any of the other medications. There was a question in the chat by Miriam about the auricular nerve stimulation. Ioannis, you want to take that, or otherwise I'll take it.
What's the question exactly?
How does it? What do you get it? How do you do it?
So there is a device. So it's already being marketed for other indications. I think for migraine mainly they use it. And it's like a bipolar stimulator that you place on your throat, and then there's another device that's actually attached to the ear. I'm not sure which one. They're transcutaneous both. I'm not sure which one they used on this. Maybe the ear device, but I can't say exactly. And that's supposed to stimulate the vagal nerve.
Yeah.
Well, they both work here at the region of the ear, but if it's auricular, I suppose it's transcutaneous device, or the ear device, and they both work on the vagal nerve, or supposed to. We don't know exactly what they do. In the study, the authors comment that they think that the reduction of parasympathetic activity would contribute to the reduction of symptoms, but the truth is we don't really know how it works. But
remember, we brought the big vagal nerve stimulation guide to our meeting in Lausanne last year, right? Bruno Bonaz, who's now
yes.
not working anymore, and he gave a nice talk about auricular nerve stimulation, and I talked to him aside from his talk. And basically, you can buy these clips which connect directly here to the auricula, to the tragus, I think it is, and this is 100%. Vagal nerve, which goes right into the brainstem. So this is your best connection to the brain. It's probably also better than anything that you use here on the neck, because you may not find the spot. The implantable ones, forget about those. There's also research about that, but that's simply not doable. So you can do the transauricular, and then there's different devices. There is the Eurostim, which is a urologic device that you may use. And then you have to use a certain program, and then you've seen the Hertz 10 or 25. Actually, the effect is supposed to be more long-term, so I'm surprised that they've done these or designed these studies so short. From what I was hearing, that the effect can increase to up to a year. So when I've started doing this, and I tell my patients to come back in 6 months, basically, to see if there's an effect. And there is now another device, the name I forgot, which is directly also available with this auricular clip, and you can do 2 times 30 minutes per day. And whether it works, I think we'll still have to see. The data that are out there are very promising. I fear that in clinical practice they won't be as successful, but Mark was, I think, rightly saying this. We are always happy to have another a piece of armamentarium to treat this population. So I think it's definitely looking at, and I mean the the importance of the vagal nerve in gastrointestinal function, both motor and sensation, is undisputed. So I think it makes sense to actually try to modify that. Not sure we're doing it the right way though, still, but this is something that I think need to follow up in the future.
And Daniel, thank you very much for that insight. How do you get that? Like, is there a prescription required for the device, or can you link the patient to an online shop, or how do you specifically get the device to the patient?
So I write a prescription for the device. It's about 300 francs, 350 francs or so. Then you can also buy it on Amazon or just if you want to do without that. But I write a prescription to give the patient a chance to get it back from his insurance. And I tell them up front, it's going to be costing that or that. If you're lucky, the insurance pays it. So this is how I do it. And then
that's
there's
the Neurostim device.
Yeah, that's true. But there's now another one, and I don't recall the name.
Okay.
Because I always give it to my assistant, and she's talked to that company, and they send it out. But I would say the cost is not prohibitive. It's really not. It's not a lot of money if you and it's a long-term use device, and you can always resell it on Ricardo if you don't like it anymore.
And I agree with both Mark and Daniel that, of course, a new tool in our armamentarium is very valuable. And we're talking about the gut-brain axis, and this is as close as an anatomical correlate to this concept as we can get. So I think there's a lot more to come from that front, I'm sure.
Agreed.
Then maybe one more question for treatment, or is there anyone from the chat? No, I don't see any questions in the chat. Feel free to turn on your camera and jump in the discussion. Otherwise, I will ask a question that it's not on my behalf. I know a lot of, or I know quite a few providers that hesitate long-term metoclopramide treatment for side effects. I don't worry too much personally about it. I've never had too bad an experience. I don't know what you guys think. I would like to hear about your experience or your hesitancy on the metoclopramide treatment.
We're increasingly hesitant. I'm increasingly hesitant. The problem is not short term, the problem is long term, regular take, and it's a lifetime dose effect that can result in neuroleptic syndromes of various kinds. And there's also concern about cardiac arrhythmias. But really, if these medications were super effective, we'd be really pushing back. But there's just been another negative study by McCallum and et al. For nasal metoclopramide in the States. And so I think it's really good if I've eaten too much pizza and I'm feeling really bloated. When I was rowing, we used to really overeat and try to get the calories in, and we used to take this and it used to really work well. We could eat as much as we wanted, but for people with painful dyspeptic symptoms, it's the mechanism of the discomfort may not be directly treated by such medications so often. So I guess I'm saying if the therapeutic benefit ratio was better,
yes,
I would try and ignore the warnings,
But that's something we can also individualize because, I mean, practically after 2-3 weeks of treatment, we can see who is responding to that and who is not. And then we can discuss risk and benefits. And I think if we get a patient in a steady state for a certain period of time, then maybe we also have a chance to stop it along the way or to reduce it and slowly to stop it completely. And maybe we have the chance to get the patient in remission, in long-term remission. Of course, maybe not only with metoclopramide, maybe we have to combine it with other things, but I don't want to tell the patients up front that we're dealing with a lifetime treatment here. So I always tell them that it's a long-term treatment, that we will go for 6 months or 9 months, whatever works, and then we'll try to stop it. We'll try to win it and see what happens.
What I have found helpful to mitigate this lifetime dose effect is in patients that have responded well, I switch to the liquid dose, and then with the drops, they can really take the minimal effective dose rather than having to have the whole, like Paspertin comes in these drops. and then they can basically titrate the dose down as they see fit, and they can go for the minimal effective dose in those who responded well in the very initial phase.
But Lukas, where in your algorithm do you start with that? Where do you place it in your algorithm?
Well, for me, it's quite late, to be honest.
Okay, and then I think it's fair, because I must say, in reality, the patients that I see, they've already had metoclopramide because they tried it themselves because they didn't feel it. It didn't work. So I never prescribe it. Number one, because I don't see good data for it. Number two, because it's a rather dirty drug. And number three, it's not made for that. And I feel conceptually it's not great.
Question: do you use Resolor for the group with dyspepsia and constipation? At least that, and do you sometimes wobble and give it to the people with?
That's a complete. I would say, how do I say this? That's a complete chance, because a lot of them, they get worse because Resolor is not great for sensation. I mean, there's data on the healthy population which shows that it actually increases visceral sensitivity. So I'm not a fan of that. However, there is patients where it works miraculously, and then I'm thinking maybe the constipation really was the main thing that was giving the negative feedback to the stomach, which may actually be the case in some gastroparetics. So in gastroparesis, I always look at what the bowel is doing, the large bowel. So in those patients, I would say yes, but I have to say I'm sometimes surprised how great it works, and I'm often also disappointed that my patients don't tolerate it.
Great. So I don't see any more questions in the chat. Then I will finish this off by thanking our speakers again for these excellent presentations and the lively discussions at the end. I do want to end with this program, so we have quite a break now, but we will be back in June talking about gastroesophageal reflux, first the diagnostic workup and then therapeutic options, and we will conclude in November with constipation, something we already briefly touched upon now with the prucalopride. We are in the process of getting accreditation for the Swiss Gastroenterological Society, so that is to be confirmed, but I hope that from June on these webinars will be accredited. Please do reach out to info@SwissNGM for further infos, and you will hear about the next webinar or get a reminder and an invitation through the same channel you have received it now. Again, thank you for the sponsors for making this possible. I think this is a very valuable addition to the Swiss neurogastroenterological landscape, and I wish you all a very nice evening. Thank you for tuning in.